Alright guys, let's review spinal disorders and exercises. You guys have had exposure to these pathologies. We're going to review some surgical interventions and how to apply exercises for patients with spinal impairments. So diving in to our spinal disorders. So we look at disc pathology, and disc pathologies are going to present with an extension bias that's going to have pain in symptom presentation that varies based on the level of herniation. So we typically see a disc herniation in the posterolateral direction, and so that's why disc pathologies typically present with an extension bias. Patients with disc pathologies typically experience radicular pain or radicular symptoms. And so looking at the definition of a radiculopathy, the patient will have pain or paresthesias along the dermatome and or decreased strength along the myotome or diminished DTRs based on the level of herniation. And so if the herniation is at L4, then we're going to see that present along the L4 dermatome, myotome, and DTR. It's important to look at centralization and peripheralization too. So centralization of symptoms is going to be when we get the symptoms to come up towards the spine. So whether we're looking at the neck and the symptoms are moving out into the upper extremities, or we're looking at the lower back and symptoms are radiating out into the lower extremities. When we have patients perform repetitive movements, we're looking at whether we see a centralization of symptoms or a peripheralization of symptoms. And so if an activity causes a centralization of symptoms, then we see the symptoms move from the periphery to the spine. And so the pain may increase in the spine or it may decrease or stay the same, but what's important is that we have decreased symptoms in the extremities. For peripheralization, we see the exact opposite, and it's where we see the symptoms going away from the spine and they're more evident in the extremities. When we look at spinal stenosis, these patients typically present with a flexion bias, and so they're going to prefer exercises that push them into flexion. And so we're going to do things like double knees to chest and trying to get those activities that are going to flex the spine more. Patients with osteoporosis are going to be at greater risk for compression fractures. We want to avoid doing sit-ups with these patients because doing sit-ups is going to increase the pressure on the vertebral bodies, which is going to create a greater risk of compression fracture beyond just the risk that they're at with the osteoporosis. And so we need to avoid dynamic trunk flexion activities with these patients. Spondylosis is going to be your arthritis within the spine, and so we're going to treat that based on patient presentation. Spondylolysis, so that's where we have a defect of the pars articularis. We don't want to extend these patients. We want to avoid that so that we don't push that vertebral body forward and increase the defect within the pars articularis to progress them to a spondylolisthesis. The spondylolisthesis, remember, is the anterior slippage of the vertebra. And so we don't want to extend these patients. It's important to note that it is most common to be seen at L5 to S1 levels. So between L5 and S1 is where we're going to see that anterior slippage of the vertebra. Cauda equina. So this is going to be impingement of the nerve roots below the termination of the spinal cord, where we've got the horse's tail that comes off. These patients may present with urinary dysfunction, especially if there's greater impingement of the nerves. They can have numbness in the groin or saddle area, and so we need to be aware of those signs and symptoms. And if a patient with spinal impairment or spinal dysfunction presents with complaints of any kind of bowel or bladder dysfunction, more specifically urinary dysfunction, but it can be bowel or bladder, or new onset numbness, tingling in the groin or saddle region, we're going to immediately notify the PT of those symptoms, because that means that the patient is at risk for something have impinged upon that cauda or caused a cauda equina syndrome. Scoliosis is going to be that lateral curvature of the spine, and so for those, we're going to stretch the concave and strengthen the convex side. Postural dysfunction, we want to stretch the shortened side and strengthen the lengthened side, and that's kind of a review of what you guys have heard for both of those before. It's important to note with postural dysfunction that forward bending with lifting places the most pressure on the intervertebral disc, followed by sitting with forward bending, and repeated or prolonged positioning can result in disc pathologies. And so we want to pay attention to educating our patients on each of those positions, especially if they have an occupation that requires lifting or prolonged sitting, and how we can help alleviate those things. For disc pathologies and patients with osteoporosis, we want to avoid the dynamic trunk flexion like we talked about for osteoporosis, but we want to remember to apply that to patients with disc pathologies as well, because this can exacerbate the disc protrusions and, again, can place an increased stress on the vertebral bodies for the osteoporosis like we talked about earlier. We also want to make sure that we follow the precautions that these outline here as far as where we don't extend and where we don't flex, but we can't assume because a patient falls into a pathology they will automatically demonstrate a direction of preference or bias. So where we see don't extend under spondylolysis and spondylolisthesis, that's because it's a contraindication because of that continued anterior slippage of the vertebra or continued progression of the defect of the pars interarticularis. But we want to make sure that if we're talking about just a direction of preference or a bias, yes, we want to know these rules and we want to understand them, but we don't want to live and die by them. We want to pay attention to what our patient presents with. So if we have a patient repeatedly perform the motion and their symptoms centralize, then we want to give them exercises that promote that direction. And so pay attention to your patient, reassess them often because that can fluctuate, especially as they progress. And remember that everybody has the God-given right to have more than one thing wrong with them at a time. And so as we fix one thing, we might see an onset of something else. And so we've got to pay attention to these rules, but we also need to pay attention to patient presentation. And so understand both the rules and how to individualize a treatment for a patient. Keep going. All right, so looking at our stages to a disc herniation, a normal disc is going to have the annulus fibrosus completely intact with the nucleus pulposus in the middle. As we progress, as a disc deteriorates, we move to disc degeneration, where the annulus fibrosus doesn't have that nice concentric shape anymore, and it's kind of stretched out a little bit more if you look on the right side of that image. Progressing from a degeneration, we move to a prolapse, and that's where the nucleus pulposus is going to insert into the annulus fibrosus, but not extend to the perimeter. The extrusion is where we're going to see the nucleus extend to the perimeter of the annulus. It's not going to go outside of the annulus, but it does go all the way through all of the layers. And then sequestration is when the nucleus extends through the annulus and is floating free within the spinal canal, like the last picture there. As the disc herniation progresses, patients typically become less responsive to exercises. And again, we talked about patients experience disc herniations most commonly in that posterolateral direction, and so that's why they typically present with an extension bias, but it really depends on which way this defect is occurring for what kind of bias you're going to see out of your patient. These are just a few of the spinal interventions that we'll talk about a little bit more in depth. So I'll move forward here. Looking at the first picture here, lumbar laminectomy, but we can talk about a laminectomy at several levels. A lumbar is just going to be your most common, but a laminectomy involves the removal of the lamina of the vertebral arch. So you can see that in that first picture. That's what they go in and surgically excise and take that out to increase the space that the nerves have to pass and decrease any symptoms that the patient's experiencing because of that compression. The second picture here, spinal fusion, involves placement of the rod to fuse spinal levels with the screw inserted into the vertebral bodies to secure the rod. And so you can see that looking at the bottom part of that second picture, those screws go into the vertebral bodies, securing the rod so that those two levels are fused together. And so movement is going to be restricted at the level of the fusion. And then the last picture here, discectomy, involves removal of part of the disc and a repair of the annulus fibrosus to decrease the effects of that herniation on the nerve root. An ACDF is a specific cervical procedure that involves the removal of the disc and the fusion of the spine, and so that's why it's named what it is. An ACDF stands for an anterior cervical discectomy and fusion. You will see it written as both an ACDF and an ADCF, but ACDF, I believe, is more common and is what the research utilizes, and so we're going to stick with ACDF for here. But basically, it's an anterior perch, so they come in through the front of the spine instead of the back, and they will fuse the cervical vertebral levels and repair the disc. So they'll remove a portion of the herniated or protruding nucleus and repair the annulus fibrosus. And then Harrington rods are specific to scoliosis, people with scoliosis, and they're longer fusion rods that help to serve as a means of preventing progression of the spinal curvature. Following any of these interventions, we're going to have precautions because they are surgical interventions. And so when we look at cervical and lumbar precautions, we'll talk about them here. So cervical precautions, we're going to look at no bending, no twisting. So we're going to encourage log rolling for bed mobility, no pushing or pulling, no lifting greater than 5 to 10 pounds, and no overhead motion so that we don't put undue stress on the cervical musculature. We want to make sure that with these patients, we're not utilizing resistance exercises immediately post-op in the maximum protection phase. Our emphasis of treatment for them is going to be placed on patient education about care and use of their cervical collar, because they're going to require a cervical collar after these procedures. Patient education regarding the restrictions and how they're going to affect their function. And so we need to think about how to apply these things that they can't do to their functional movements, how to teach them how to do it, and then the functional training to comply with those precautions. For lumbar precautions, we're going to think of BLT, so no bending, no lifting, no twisting. And again, we're going to promote log rolling for bed mobility. Same thing as far as educating a patient on the need for bracing as indicated by their surgeon. So not all lumbar surgeries are going to require an LSO or TLSO following surgery, but it's important to familiarize yourself with the surgeon's orders so that you are educating your patient appropriately and training them to do functional things within the compliance of their precautions. Basic interventions for spinal rehab are going to follow this continuum, where the first step in training a patient with spinal stabilization techniques should be teaching awareness of safe spinal motions and functional positions. Every patient with spinal impairment should learn kinesthetic awareness of safe spinal positions and movements, activation of deep segmental muscles, and global muscle control of spinal postures when they're incorporating dynamic movements, especially. So being able to find that posture in a neutral position, but also being able to layer in dynamic movement of the extremities. We want to make sure that we have all of these things in place before we try to progress a patient to basic and advanced training exercises, because stabilization is at the root of spinal dysfunction. It's a stabilization defect, and so we have to have the proper kinesthetic awareness and control before we can move on to any additional steps. Spinal rehab should include kinesthetic training as the very first step, and this is going to include awareness and control of safe spinal motions. We can use things like head nods and pelvic tilts to achieve this. Both of those are going to be used to perform range of motion activities of the lumbar and cervical spine, as well as teaching a patient how to achieve spinal neutral and what that really means, because that's a big deficit for a lot of patients, is understanding where spinal neutral is. So continuing to promote that awareness of a neutral spine using supine position to start, because it is the most supportive and comfortable prone positioning when not contraindicated, progressing our patients to sitting and standing from there to increase the challenge and apply it to function. We can also utilize quadruped instead of prone when patients can't get into prone. Or we can bridge the gap between supine or between prone and sitting with a quadruped, because it's a little bit more strain on the spinal musculature without being completely against gravity. And then awareness of activity effects on the motion of the spine, so making patients aware of how their spine moves when they move and what they need to do to maintain spinal neutral as they move through life. Then we'll progress on to stabilization training. Deep segmental muscle activation, so we're looking at transverse abdominis contractions, we're trying to get multifidi activated, all of those smaller muscles that shut down when there isn't enough awareness and neuromuscular input. Those are the ones that we need to wake up first. And so a lot of our training for spinal stabilization is about using kinesthetic awareness, using proprioception, using all of those sensory inputs to understand how to activate those deep segmental muscles for stability. For cervical spine, we're going to do controlled axial extension with upper cervical flexion and lower cervical extension. So that's going to be like our chin tucks. And then for lumbar, we're going to do our transverse abdominis contractions or our drawing in maneuver. And like we talked about, multifidi activation. And multifidi activation is going to be most commonly achieved moving from a flex position up to a neutral spine, not necessarily cranking back into extension, because that doesn't typically tend to be the most comfortable for patients, with the exception of patients with an extension bias. But again, how we progress that is going to start at a very low level of movement, because cranking into extension usually isn't comfortable for anybody to start. Once we have appropriate muscle activation at those deep levels and we don't have the bigger muscles taking over, like our rectus abdominis for the anterior or our rector spinae for the posterior, we're going to implement more functional training. So we'll teach patients about moving from supine to prone, prone to supine, from supine to sit, sit to stand, and transitioning in all those directions, all while engaging those stability muscles, looking at the deep segmental muscles more than, again, rectus abdominis or erector spinae. With patient education for spinal rehab, we need to make sure that we are talking to our patients about what is really important to them as far as their goals for rehab and how we can help them achieve not only their goals, but also a realistic outlook on what those goals are. We want to educate them on the stages of healing, because it's easy to get discouraged, especially when you've just had surgery to treat a chronic back problem and you want quicker results. And so we need to provide ample education regarding that. Signs of exacerbation of symptoms are going to be important to educate a patient on, because that's going to help tell them what their biases are and what they can do to alleviate symptoms and what activities to avoid. People with prolonged sitting demands are likely, or people who have pain, or people who have back pain, but also have something that gives them prolonged sitting demands, like their work tasks. We're going to want to educate them on paying attention to when they start to get uncomfortable and interrupting those prolonged flex postures with periods of standing to alleviate that discomfort and symptom management. Um, on the flip side of that, if we're not sitting for prolonged periods, but it's an issue with lifting, we want to make sure that we're teaching them pelvic tilts and how to maintain a spinal neutral and avoid any exacerbating positions when performing their lifting tasks. We want to educate patients on the progression of their activity and not pushing it too far too fast, but also on appropriate levels of challenge so that we are applying the overload principle. And then as far as prevention, using appropriate body mechanics, ergonomics, stress relief, we want to educate them on sleeping positions. So patients with a flexion bias, we're going to encourage them to sleep on their backs, maybe put a pillow under their knees to help increase the flexion of the spine as they sleep. If a patient demonstrates an extension bias, we're going to encourage them to sleep on their stomach and alleviate their discomfort that way, because somebody who isn't getting enough sleep is probably not able to give everything that they need to in rehab, whether that's a matter of paying attention in the clinic or carry over and paying attention to spinal neutral in their day-to-day tasks. There are 5 components of exercise for spinal rehab, and we've talked about kinesthetic awareness, mobility, flexibility, and functional activities. But we also want to consider that we've had patients experiencing levels of deconditioning, and so we need to look at muscle performance and cardiopulmonary endurance as well in implementing our spinal rehab treatment plan. During phase 1, so this is going to be our early training, it's going to be maximum to moderate protection phase. We're going to focus on kinesthetic awareness with things like pelvic tilts and cervical retraction. Pelvic tilts in supine for lower back dysfunction, and cervical retraction also in supine for cervical dysfunction are going to be important for initiating exercise in order to increase that awareness and finding a neutral spine position. It will help us also identify aggravating and alleviating symptoms, and again, carry over for that education on what a neutral spine is to achieve that through their day-to-day life. And we're going to work from passive to active assistive exercises so that the patient's really able to understand what neutral is, and it's just a big awareness piece. For mobility and flexibility, we're going to emphasize trunk stretching in pain-relieving positions, extremity stretching, and grade 1 and 2 mobilizations for pain management as appropriate. Muscle performance is going to focus on activation of deep muscle stabilizers, so our drawing in maneuvers, our chin tucks, our multifidi activation, and stabilization exercises with extremity loading as appropriate, so we want to progress the patient appropriately. Cardiopulmonary endurance is going to be performed only if it's tolerated with a maximum protection for comfort. A lot of times we'll get better tolerance when we perform these activities in a seated position, so looking at something like the new step or the bike to promote cardiovascular endurance, but also cardiopulmonary endurance, but also while providing support to the spine as needed. And then functional activities are going to emphasize safe postures and spinal stabilization techniques for those functional mobility tasks that are most important. If those functional mobility tasks are limited and the patient has a deficit of independence, and we're going to have to emphasize caregiver training. It's really important in this stage that the caregiver is aware of being careful with transfers, especially. You want to make sure that we educate them clearly on not doing any quick transfers. We want to limit jarring motions. We want to limit quick decelerations. We want to limit plopping the patient as we transfer them. Like, the spine is something to protect. And so if independence is limited at this stage of the game and we're doing caregiver education, it's important that we're giving those safety considerations in our education. As we progress to the moderate to minimum protection phase, our kinesthetic awareness is going to involve increasing the challenge to the spine. So we're going to have more active control of the spine, and we're going to progress through more challenging positions. So moving from supine to prone to quadruped to sitting to standing, in increasing level of difficulty with those positions there. We want to have the patient perform dynamic maintenance of pain-free positioning with activity. So what that means is implementing upper and lower extremity motions into maintaining a neutral spine while moving the upper and lower extremities within a pain-free range of motion. Mobility and flexibility are going to include gentle spinal movements in pain-free ranges, focusing more on stretching the upper and lower extremities and less on stretching the spine. Part of that has to do with protecting the tissues. The other part has to do with the fact that a lot of patients rely on the inherent tightness of muscles to cope with pain, and if we stretch the spine too much, we take away that tightness that's providing them the stability, and we can exacerbate their symptoms. For muscle performance, we're going to look at stabilization exercises with extremity loading, emphasizing muscle endurance, adding in perturbation training, and low-intensity dynamic spinal exercises. Cardiopulmonary endurance is going to be low to moderate intensity, using activities that emphasize the spinal bias of the patient. So again, trying to connect it with the patient's spinal symptoms, but also promoting that cardiopulmonary endurance. And then functional activities are going to progress to strengthening the upper and lower extremities while stabilizing the spine, educating and practicing performing things with proper body mechanics, environmental and ergonomic adaptations that they might need, and how to implement those in whatever environment is necessary. During phase 3, our kinesthetic awareness is going to involve educating the patient and challenging the patient to maintain a neutral spine through the performance of all activities at increasing levels of difficulty. Mobility and flexibility are going to target on moving into painful ranges to stretch, because we're hoping we have the appropriate muscle activation, that we don't have to rely on that inherent tightness, and now we can push into those uncomfortable ranges to stretch. I don't know if painful is the best word, but uncomfortable ranges to stretch. Muscle performance is going to focus on stabilization with transitional motion and functional activities. That I think of that return to activity phase with continued dynamic trunk strengthening. Cardiopulmonary endurance is going to push towards more high intensity, encouraging patient to participate both in therapy and out of therapy so that they get multiple times per week. And then our functional activities, again, thinking return to activity. So high intensity functional activities is going to be what is high intensity for that patient. So remember, patient specific, but building overall endurance and strength to restore independence to prior level of function. So we'll go through some picture examples, and I'm going to refer you to some videos for exercises, but some exercises for increasing thoracic extension. We can have a patient lying along a foam roller, implementing shoulder flexion or scapular retraction are both going to help encourage thoracic extension. And so we want to start with just laying there and see what the patient can tolerate and add in those upper extremity motions as the patient can handle it. We can also increase thoracic extension by having a patient stretch over a chair. So, leaning back with the chair targeted at the area that needs mobilization. It's a self-mobilization technique that patients can perform on their own. Manually stretching the scalenes. So we want axial extension, side bending away, and rotating toward the muscle. Honestly, with the cervical spine especially, and stretching, I think you want to move the neck in the direction that you feel the most restriction, because we have muscles that pull in several different directions coming from the anterior and posterior aspects of the cervical spine. And so it may be the scalenes that are tight, but then it's the upper trap that's contributing, or it's the levator that's contributing. And so you want to feel the resistance when you're stretching the cervical spine, but knowing that if you're going for the scalenes or the upper trap or the levator, and these are muscles that attach to the shoulder girdle, we want to stabilize the shoulder girdle with one hand while we stretch with the other, because otherwise we're just going to get elevation of that shoulder girdle. With a suboccipital stretch, you can perform it for the patient by applying pressure to stretch that suboccipital region, or you can instruct them to self-stretch. I think this infographic has good instructions for a patient. So place your fingers on your chin and retract your chin back so your ears are aligned over your shoulders. Take your other hand and place it on your top of the head and press down gently. You should feel the stretch in the back of your neck. Hold the stretch for 30 seconds. I think that those are good, clear-cut instructions for a suboccipital stretch. Remember that forward head posture puts a lot of patients predisposed to suboccipital shortening. And so this is a good stretch to know and know how to educate somebody on how to perform. Other important muscles to consider for self-stretching, especially in the cervical population, are going to include pec major and minor, levator scap, and your shoulder internal rotators, so your subscapularis primarily there. We can always consider traction as an intervention for spinal rehab because of its ease of implementation to perform cervical traction manually. As far as using the traction table, you guys don't have to worry about utilizing that in your treatment plans or for your assignments or your demonstrations or your practical, but if you are going to utilize traction as part of your treatment plan, it's how can we perform manual traction. And so review those techniques and talk to me if you have questions on how to apply it. I personally prefer to use a towel when I'm doing manual traction of the cervical spine because it gives me better hold of the patient, but I don't know if that's been demonstrated for you guys, so let me know in class and we'll talk about it. A great exercise for lumbar flexion is to have the patient pull their knees towards their chest and hold it. This is probably the most effective way to stretch tight lumbar extensor muscles and just pull it in a way to pull them into lumbar flexion. Other lumbar flexion exercises to consider for our patients with a flexion bias are going to include anterior posterior tilts in quadruped and stretching into a child's pose position. We can also have the patient reach towards one side or the other to increase for lateral flexion, but we have some more lateral flexion exercises we can talk about here. For lumbar extension, we want to use these exercises for patients with an extension bias. Typically, patients with a disc pathology are going to be our ones with an extension bias. We do not want to use these exercises with patients with a spondylosis or spondylolysis or spondylolisthesis because, again, we do not want to extend these patients to prevent anterior movement of the vertebral body. But we want to look at each individual patient and see how it applies to them with those exceptions. Progressions for these exercises may start with the prone propping on elbows to get comfortable with the position, and then we move the patient to a prone press up like we see on the left, both of which are going to give stability to the pelvis because the patient's laying in prone to allow activation of the trunk extensors. And then we can progress the patient to seated or standing lumbar extension exercises where they can do standing back arches like on the right. A lateral trunk flexion exercise seen here, the therapist is stabilizing the patient's pelvis and instructing the patient to reach down along their leg with the arm that's down and then up above the head with the arm that's up to open up that left side of the spine. Another way that we can implement this is to have the patient inside lying to where they can reach that arm or that upper arm over the head and off the table. In a patient who's extremely stable, you might be able to push them a little bit further off, but I would still keep the shoulders supported on the table to increase stability. You also make sure you have your hands stabilizing the pelvis so that way they can enhance the stretch on their own, but they're not having the pelvis just pull up along with them. And then the picture on the right is going to be the picture or what we talked about as far as child's pose moving off to one side or the other to increase the stretch on the lateral aspect of the trunk. And then this is the picture of the patient hanging off the side, but I would encourage that you keep your patient with at least the shoulders on the table. You can try this with your family at home who don't care if you let them fall off the bed or the table, but I would be cautious with applying this technique with patients in the clinic. To combat forward head postures, we can use exercises that promote axial extension. And so a good cue to give patients for this is to think like a string is pulling straight up from the crown of their head. And as that string is pulling up, they should feel their chin tuck and their shoulder blades pulled down and back. So we get scapular retraction and depression as well to really combat that forward head kyphotic posture. Stabilization feedback devices, they have specialized feedback devices, but you can utilize things like a blood pressure cuff, and I believe, have a component of that on your spinal rehab lab, but either way, we can talk about practicing it in class. But basically, you pump up the device to a prescribed millimeters of mercury, and you have the patient hold a neutral spine position that keeps the device at that millimeters of mercury, and you have them slowly move off of it and back onto it, and so that they have this biofeedback that tells them when they are maintaining a neutral spine. We can use this in the cervical spine below the neck or underneath the neck, or we can use this in the lumbar spine just above the pelvis through the lumbar vertebra. So for utilizing things like the spinal stabilization biofeedback devices, we can have the blood pressure cuff under the upper cervical spine and we can inflate it to 20 millimeters of mercury. Instruct the patient to nod and increase the pressure to 22 millimeters of mercury and hold it for 10 seconds and have them relax, and then increase the pressure gradually up to 30 millimeters of mercury. So can they nod, hold up to 24, nod, hold up to 26. And so we're changing that position. We're also changing the resistance that we're asking them to push into because we're increasing the pressure that we're asking them to achieve. And so that's going to promote deep segmental muscle activation, but also muscle strengthening. And then muscle endurance is measured by the number of 10-second holds at the final pressure that the patient is able to perform and hold at that pressure. So I'm going to have you guys pause from this video right now, use your FA Davis account to log in and look at your Therex 1 textbook links, and you're going to watch the videos that correlate to this for 16.2 and 16.12. So if we want to increase the challenge of gravity, we can have a patient perform chin tuck exercises in prone. And this isn't a great picture of it, but it's a picture of it. I don't know a whole lot of patients who like laying with their face smushed into the plinth like that, but it is an option. We can look at stabilization exercises increasing in difficulty, whether we are taking away support from the patient or we're increasing the extremity loading. So this applies to both cervical and lumbar spine, but it's a good outline, and so I would make sure that you can understand the outline here and the suggestions that are being made based off of this outline, to apply it in concept to both the cervical and lumbar spine and not just memorize this table. But basically, it talks about starting with deep segmental activation, using chin tucks for 10 seconds and 10 reps, starting in supine position, then moving to sitting on therapy ball for less stability, then standing with wall support, then standing with no support or on an unstable surface. And so after we have appropriate deep segmental activation, moving from maximum support to minimum support, then we can increase the limb loading. And so as the patient progresses, we're going to maximally load the limbs at the minimal support level. And so following that progression can help you determine what types of exercises and what positions and ways to implement those exercises. There's some more example videos on your FA Davis account, so go ahead and click back over to that tab and watch videos 1615 and 1616 for cervical stabilization exercises of the cervical extensors. Cervical and scapular stabilization are going to go hand in hand with a lot of patients. Scapular dysfunction tends to come with cervical dysfunction, and a lot of that is posturally related, and so it's important to pay attention to those. So these example exercises here, having a patient seated on a ball, that's going to challenge their trunk stability inherently because they're on an unstable surface. And then we're adding limb loading, so having the patient do upper extremity or overhead motions rather, but then challenging them further by adding resistance into it. We can have the patient prone over the ball and activating that axial extension and maintaining the chin tuck while they do internal external rotation of the shoulders and scapular retraction to get scapular stabilization there. We can also put a ball behind a patient's head and have them maintain a chin tuck while they have them do shoulder flexion against gravity in an alternating pattern. All of those things are going to increase the dynamic challenge to the cervical stabilizers and the scapular stabilizers. It's important to understand the difference between drawing in maneuvers and bracing maneuvers. So drawing in maneuvers are going to be more of your transverse abdominis contraction, and that's going to be your draw your belly button in towards your spine. Bracing is going to be where you tense everything up and you tend to push your stomach out to tense and brace. And so bracing has more activation of rectus abdominis. And so we want to educate patients on the drawing in maneuver and not use of the bracing maneuver. Patients tend to brace. That's part of why rectus takes over and transverse shuts down. And so we need to educate patients on that drawing in transverse abdominis activation. And pelvic tilts work to promote range of motion of the lumbar spine and help improve kinesthetic awareness of spinal neutral. Go ahead and take a look at videos 1613 and 1614 for some lumbar musculature exercises over abdominal bracing, posterior pelvic tilt, and multifidus activation and training. I know I just got done saying that we don't want our patients to brace, but it is something that we may need to incorporate to improve abdominal stability as long as we have first educated them on the drawing in maneuver, transverse abdominis activation, and emphasize those deep segmental muscles and not the more superficial muscles. Go ahead and also watch videos 1617, 1618, and 1619 for more lumbar stabilization exercises. So a couple things to keep in mind with these lumbar stabilization exercises, and we're going to start in the top right corner when we're talking about this, where we're looking at our dead bugs. And we also want to keep in mind this information for when we talk about women's health coming up. Dead bugs are a great exercise for women postpartum because they're going to help to improve abdominal strength in the supine position, which is going to give stability to the spine and pelvis while we can implement movement of the arms and legs to provide a dynamic challenge to the abdominal muscles that can be progressed by starting with just alternating our upper extremities, and then we can implement movement of the lower extremities, and then we can add weights to them to continue that progression, but all while maintaining a supportive position for that patient. And so understanding that This picture demonstrates movement of lower extremities first. You can start with upper extremities or you can start with lower extremities, but you're only moving one or the other first. Then you move both upper and lower. Then you add weight to it. The other picture demonstrated here, once patients don't require the support of supine, we can progress them to quadruped. We can progress them to prone when tolerated, but remember, a lot of patients don't tolerate prone, and so we may utilize quadruped more often. And so transitioning to quadruped gives us a greater challenge than supine, but it's not quite as challenging as seated or standing. And so it's a good intermediate step for patients. And so what we see the patient doing here are our bird dogs, and I may have called the other ones bird dogs. And either way, we've got dead bugs on your back and bird dogs on your hands and knees. But bird dogs are performed in quadruped with the same goal of providing a dynamic challenge to the trunk through those alternating arm and leg movements. And we can utilize the same progression that we talked about with the dead bugs, where we have just upper or lower extremities moving first, then both, then adding weight. And we don't even have to have full range of motion of the upper or lower extremities when we start. As you can see in this picture here, this patient starts by just sliding their right knee back to initiate that movement. It's not a full motion of the lower extremity through hip range. And so we have to take our patient and start them where they are. Meet your patient where they're at. And then the cane that you can see on this patient's back is just to help give them a tactile cue for maintaining a level trunk and pelvis. So go ahead and switch back over to your FA Davis tab and check out videos 1620, 1621, 1622, and 1623 for some advanced spinal stabilization exercises. And we will go ahead and try to apply those when you guys come into class.